Welcome to the People's Health Briefing, a component of the Trusted Voices campaign. I'm Dr. Noha Balata from Roots Community Health Center, reporting for the week of June 19th, 2023. After a brief update on COVID status, I'll review the FDA's recent deliberation and recommendation, and I will briefly touch on a recent study about COVID and the brain. As health professionals rooted in Oakland, serving some of the people most vulnerable to getting and suffering from COVID-19, we're here to cut through the noise to give you information you can use to make choices that will keep you, your loved ones, and your community as safe as possible. The goal of the People's Health Briefing is to empower you with our best knowledge and thinking every Tuesday morning. Taking a look at the CDC COVID data tracker, we can see that there were 6,649 hospital admissions in the week ending June 3rd. So we're continuing to see a downward trend there. And we're also seeing a downward trend in provisional COVID deaths. So far in the United States, over 1.13 million people have lost their lives to COVID-19. 39,960 of those have been this year in 2023. The last week that we have our confirmed death numbers is the week ending May 20th, and there were 684 deaths. And this is the 7th week in a row that we've had declining numbers of deaths. So this is certainly good news. Taking a look at wastewater, this CDC map is showing where in the country SARS-CoV-2 has been detected in the wastewater in the last 15 days. So this isn't about the concentration in the wastewater. This map is actually about the percentage of samples that have SARS-CoV-2. So with all those red dots, this is just really showing us that of the places in the country that are measuring and reporting wastewater at this point, the vast majority of them are detecting SARS-CoV-2. To see recent change, we can take a look at this map, which shows the percent change. This one shows which are increasing. Those are the warmer colors of the reds and oranges. The yellows are very slightly increasing and the blues are decreasing. The dark grays, unfortunately, show where there has not been any recent data reported. So basically looking across the country, we can see that there are a lot of areas that are not reporting at all. And where they are reporting, we're going in all different directions. So it kind of depends where you are. So you'd have to drill down into your area. This map is linked in the post, and if you want information, you can try focusing in on your area with this map. But I've also noticed that some areas are reporting on the CDC map and others aren't. But just because they aren't doesn't mean that they aren't analyzing wastewater. So you might be able to find more accurate information for your particular area by looking at other resources, maybe at the state level or the local level. I've actually been asked about this a lot since we've lost other important data sources like case counts, but there are many different wastewater sources. I'm going to share one today called WastewaterSCAN. Here is the WastewaterSCAN dashboard. And this dashboard has sewer sheds from all around the country, some more sparse than others, but it doesn't seem to be completely overlapping with what the CDC or other sites are showing. So it just might be that it's helpful to check your area. And here, if I'm looking at the East Bay and East Bay Municipal Utility District, and we can see that they're monitoring a number of different pathogens in the wastewater. And you can see that all of them are pretty much low. SARS-CoV-2 is certainly present in the wastewater, lower than it's been, but something that we'll continue to keep an eye on. I just wanted to share this particular wastewater resource because it might be a good one for you depending on where you are in the nation. Taking a look at variant proportions, this is the exact same slide I showed last week because you'll recall that CDC has gone down to reporting this tracker every other week. But I'm showing it today because it's relevant to the FDA's recent discussion about plans for future COVID vaccines. So as we can see here, we are dealing almost exclusively with XBB. And XBBs are all in the Omicron family, but they do look quite a bit different than some of our prior Omicron strains that we were dealing with before. And the XBBs resulted from what's called recombination between two previous Omicron lineages, which were both lineages of the BA2. And this recombination is one of the many frustrating things about SARS-CoV-2 that's actually different from a lot of other viruses. And it's actually a frustrating thing about coronaviruses in general, which are basically a very long strand of RNA that can recombine with a different SARS-CoV-2 variant to come up with a basically new and improved from the virus standpoint version of itself. And so this has happened a number of times already in the pandemic, and it results in a virus that has some kind of advantage or competitive edge over the other ones. And this recombination can really only happen between two variants that are circulating at the same time. And this is what happened before with two different lineages of BA2 that basically recombined to give us the XBBs that we're dealing with now. And these are the most contagious variants that we've dealt with so far. And they've gotten pretty far away genetically from the previous Omicron subvariants like the BA4 and the BA5. And they've gotten really, really far away from the original so-called Wuhan strain or the original strain of SARS-CoV-2. So what the FDA discussed in its June 15th meeting was what this all means for vaccines and vaccine boosters when we say that the current circulating strains of SARS-CoV-2 are no longer close to the ones from our original vaccine or even our bivalent vaccine. So remember the bivalent boosters that became available last fall, those contain BA4 and 5 plus the original SARS-CoV-2 strain, and that's why it's called bivalent. And that may have been fine for what was circulating at the time, but it is clear that this is no longer going to cut it. So the point of what they were considering is shown here, basically, that by several measures, including escape from antibody neutralization, so meaning prior infection, antibodies that you might have gotten from getting the vaccine, and waning protection, so the wearing off essentially of protection that you might have if you've been vaccinated some time ago. The current COVID-19 vaccines appear less effective against currently circulating viruses than against previous strains. And manufacturers of authorized approved COVID vaccines, so that would be in the United States, Moderna, Pfizer, and Novavax. These manufacturers have been evaluating updated candidate vaccines at risk and are prepared to provide an updated vaccine. And at risk means they're paying for it themselves. So up until now, there's been a lot of government funding for these endeavors. And as we move into the commercialization of the pandemic response, and we know this was part of the decision to end the emergency declaration, that we are moving into trying to handle this like other viruses. So the vaccine manufacturers are going to be footing more of their own bill. And as you can see at the bottom there, it says manufacturing timelines may be impacted by the final choice of vaccine antigen. And it became kind of clear through the discussion that strain selection, so which strain they pick to make the booster from, is going to be an important factor that plays into how quickly a booster can be made and deployed. So there was actually quite a bit of discussion about this part, about an updated vaccine for 2023-24. And some of the committee members really didn't like this choice of words because they felt like it implied that this is going to be an annual thing when really we have no idea. And they felt that was going to be confusing, perhaps, for the public, but also just that it wasn't really an accurate representation because we actually don't have any reason to think it would fit into an annual or seasonal pattern at this point. But the argument was also made that they want to call it the 2023-24 because of how long it's going to take to actually manufacture and deploy these vaccines, that basically the notion that we would be doing anything else in 23-24 was highly, highly unlikely. But Ultimately, they did clarify that if there was a dramatic event, such as a new variant that evades all of this, then absolutely they would need to do something else in 23, 24. So maybe it seems like a little bit of semantics, but I thought it was an interesting discussion because it's kind of balancing the reality of COVID and what SARS-CoV-2 is doing against the reality of what's actually reasonable and feasible from a practical standpoint of producing and distributing new vaccines as we need them. And where they landed was, barring something dramatic, whatever we come up with for the fall, this fall, is what essentially we'll be likely working with for the next year or so. They also suggested that by next fall, there will probably be enough drift so far away from the SARS-CoV-2 we're dealing with now that we'll probably have to do this again. Again, emphasizing that this is not seasonal or predictable, but kind of trying to add some kind of practicality. The other practical matter they raised is that they want to try to synchronize with the rest of the world on what strains are being used and roughly the timing of deploying new vaccines. So the questions before the committee were, should there be a change from what we have now? And again, that's the bivalent booster. And there were hours upon hours of data presented by the CDC, the FDA, Pfizer, Moderna, Novavax, and a very robust discussion among the committee members. It's over an 8-hour meeting, so if you want to, if you're really interested and want to get to the heart of the matter, towards the end at about the 6-hour and 50-minute mark, the link is in the post if you want to check it out. But there was a lot of data that kept kind of showing and re-showing and confirming or supporting the notion that, first off, there's no more need for the Wuhan strain in any of our vaccines. So that needs to be removed. It's really sort of no longer relevant. So the original vaccines that we got are no longer relevant or needed. There's also no more need at the moment for BA4 or BA5. And really, it's all about the XBB at this point. The other question before the committee was, should it be bivalent or monovalent? And again, based on all the data that was presented, there seemed to be quite a bit of support for the fact that we only need a monovalent vaccine, and it should be some selection of XBB lineage. And the good thing about all those XBBs that we're seeing right now on the variant tracker is they might be far away from the other ones we were dealing with before, but they're all very close to each other. So this is actually really important because now there doesn't seem to be a need for anything bivalent. If it's going to be good for one of the XBBs, it appears that it will be good for all of these XBBs anyway, because there's a lot of what they call cross-reactivity. So if you make antibodies against one of them, you should be well protected from the others. So all in all, that part is good news. So the 21 members of the VRBPAC committee voted yes, there should be a change. It should be monovalent. It should be XBB. And then there was a discussion that I won't get into too much detail about on which XBB should it be, 0.1.5 or 0.1.16 or 0.2.3. And my interpretation of where it landed was that, like I say, there's good cross-reactivity between all the XBBs, and that XBB.1.5 seems to be a good choice because they have more experience with it. We've had more time with it. Remember, this was the one that had almost taken over completely at one point until the other XBBs came on the scene, and now it's decreasing, but it's still circulating quite a bit. So there's good cross-reactivity. If we go with XBB.1.5, it will provide good protection against all the XBBs according to their analysis, and that we also have more information, more data about it, and so it could be developed and deployed the most quickly among the XBBs. So the committee seemed to agree that XBB.1.5 was the most preferable strain to select for our next round of boosters. And that was a unanimous vote, and the manufacturers seemed to be indicating that this new booster, monovalent booster, could be available in September or early October. So we'll certainly be looking out for any updates as well as any decisions by the CDC about who will be eligible for what. I appreciated one of the committee members in particular, Dr. Hildreth, who brought up access. He brought up the fact that people should have access to the Novavax vaccine, which has been less available than the mRNA vaccines. He also spoke to access in general, given the commercialization of the pandemic response and kind of moving into how other things are covered in healthcare or not, and how we need to make sure that the uninsured and underinsured retain access. So I appreciated those comments. And everyone on the committee seemed to be in agreement about the fact that this is not it's really not an annual or seasonal type of situation. So we shouldn't try to pretend like it's the flu. They all agreed we'll be back at this point again by the looks of things because this virus continues to evolve, and that it's unlikely that this is going to be like, let's say, like an MMR vaccine or something that we don't have to change, at least not anytime soon, if ever. So even though there might be some similarities with how we respond to the flu in terms of doing something annual, it's really for ease of process, not because this is a seasonal or annual situation, at least not yet. So there was a lot of discussion about this, trying to make sure that we were not confusing people. They want to make things simpler, but we don't want to misrepresent the situation that we do continue to be in an evolving situation with SARS-CoV-2. It's a very different picture than the flu in many, many ways. And I actually went into a lot of detail about the difference between COVID versus the flu in a prior briefing, which I also linked in the post if you want to check that out. But here's yet another example of how COVID is not the flu. This is a new study from the journal Science, and it made some headlines. So I thought I'd touch on it briefly today, even though it's fairly complicated, a laboratory type of a study. But I did do a deeper dive on the cognitive issues that we're seeing clinically with COVID infection in a prior briefing, and that link is in the post if you want to check that out. But this particular study, and like I said, was really kind of complicated scientific study, really fascinating, a little frightening, but it showed that being infected with SARS-CoV-2 can actually cause the nerve cells in the brain, or neurons, to become fused together. So that's definitely not good news. Certainly, we're going to need more study to really understand what this means clinically. This study was looking kind of on a microbiology level, looking at cells under the microscope, and even looking at kind of a mini model of the brain called mini brain, which is created from stem cells to be able to analyze things in the lab. So pretty amazing science. And it always does take time for things to go from science in the lab to what it's going to mean in real life. But their findings were certainly striking and very concerning, and may help explain some of what we're seeing in real life as it relates to post-COVID. And what this picture is showing here are neurons of a mouse, and those are the normal ones are in magenta. And the yellow there, that's not normal. The yellow is where the neurons have become fused to each other. And this can cause kind of like some short circuiting. So these researchers basically discovered that SARS-CoV-2 can cause brain cells to fuse, and that does lead to malfunctions. And those malfunctions may be what's leading to the chronic neurological symptoms in people who've had COVID. And now these are researchers who study the impacts of viruses on the brain, and what they discovered here with COVID is something they hadn't seen before in the brain with other viruses. They've seen it in other tissues of the body with viruses like HIV or rabies or Zika virus, but not the brain. And so now they're wondering and asking if maybe this is going to give us some clues to some of the neurological effects of other viruses, like the ones I just mentioned. And so they're wondering in general if this fusion of neurons could be a cause of other neurological diseases. And so that would obviously need further exploration, but this definitely gives hope because a lot of the neurological diseases are a bit mysterious. So the more we can unpack and find out because of all this accelerated research is definitely hopeful for a lot of people. And I did read an interview with one of the lead authors of this paper, and I liked the analogy that he used about what this means. He made a comparison of wires that are connecting switches to lights in the kitchen and the bathroom. And if those wires got fused together by accident, then in that case, either switch could turn on both the kitchen and the bathroom lights or neither the kitchen or the bathroom lights. So basically, and I quote, it's bad news for the two independent circuits. So that's, of course, very concerning stuff. It's unusual. We're going to need more study, but there is quite a bit of evidence for neurological and psychiatric impacts of COVID infection, changes to the brain, even from mild infection. You can take a look at the prior briefing if you want more details about some of those findings, which include MRI findings and laboratory findings and so on. So as we're learning about all of this and as we continue to be in an evolving situation, we're still wanting to do what we can to avoid infection and reinfection. Also, we'd like to prevent outbreaks, particularly among people in congregate settings, among vulnerable people, and really anywhere where people gather, like schools and other venues. But particularly, we want to make sure that people can access services safely. And so I want to bring your attention to an upcoming workshop that's being put on by Seniors in Disability Action, DREDF, and others who are fighting for safe access in a mask optional healthcare environment. So that is very disconcerting that there are healthcare environments that are taking care of sick and vulnerable people that don't mask. Fortunately, where we are, we still have institutions like Alameda Health System who are still masking, Roots Community Health Center is still masking. A number of us are still masking, but many are making it optional. For some reason, this part of infection control is becoming optional. Don't quite understand that. But there is a workshop coming up next Tuesday at 12:30. The link is in the post. It's a workshop on making accommodation requests and essentially advocating to ensure that everyone, particularly those with disabilities, can safely access the services that they deserve and that they need to be able to access safely and without fear of an airborne virus infection. So I'd encourage you to check that out and spread the word to those who might be interested. And let's keep up our best practices to prevent the spread of COVID, including being up to date on vaccination, wearing high quality filtration masks like N95, KN95, or KF94. And let's please still wash our hands. We want to avoid not only SARS-CoV-2, but other things as well. Very importantly, if you are going to be indoors, you want to make sure there's good ventilation and filtration. You can assess ventilation using a CO2 monitor. Limit your time indoors, limit the amount of mixing you're doing, and whenever possible, gather outside. If you'll be gathering indoors, you might also consider implementing pre-gathering testing as another layer of protection. And something so critical that we do not want to forget or overlook is that if you are someone who should be treated, if you catch COVID, then you should know that in advance and you should have a treatment plan. Discuss this with your medical provider. The link is in the post to the CDC list of conditions that mean that you may be at risk of a bad outcome. And if you're at risk of a bad outcome, and that's anyone 50 and up, and people with these underlying conditions. So even if you're 50 and up with no underlying conditions, you're still someone who's potentially at risk of a bad outcome. And that means you're someone who should be treated because treatment can reduce the risk of hospitalization and death by about 80% if you started on time. And starting on time means you got to test on time. And it means you have to be able to access your doctor or just have a plan all ready to go. So this is very important. Anyone 50 and up, as well as anyone with underlying conditions, make a treatment plan. If you don't feel well, please stay home and rest. Don't spread what you got to others. And also, resting is important for your thorough recovery. Remember to eat a balanced diet, incorporate fruits and vegetables, some whole grains. Let's avoid those sugary drinks. Consider a multivitamin supplement. get your blood pressure checked, get your baseline labs checked, like sugar, cholesterol, vitamin D, get some regular physical activity. Unless you're sick, then please get your rest, manage your stress levels, and get a good night's sleep. This concludes today's People's Health Briefing. Thank you so much for joining us, and we'll see you again next Tuesday at 10 a.m.